Karen, is there a clicker?
So my second first time. Oh, there you go.
Okay, I'll just.
It's fine, I can do it.
I'm sorry, over here. And usually. You can advance the slides to the next slide.
Some of them I'm going to go right, so. The rest I'll walk through.
Okay.
We'll make it.
All right, sorry for the delay. Let's go ahead and get started. I hope everyone can hear online. Can we confirm that you can hear us okay?
We can hear you.
Thank you so
You
much.
can hear me
Karen.
okay?
All right. Well, we apologize for some technical difficulties. We're grateful for everyone joining us both here in person and remotely and from throughout the state. Thank you for your attendance. I'm very pleased to be able to introduce Melinda Kent, who is the Associate Director of the CMQCC, overseeing the Maternal Data Center. Melinda has a long career, including an important career as a bedside labor and delivery nurse, from which she got her start in both IT, working with electronic fetal monitoring startup in California and throughout the United States. And then she found herself in a quality role where she found her passion for doing this work and melding IT and quality improvement and bedside expertise. And then she was named to the associate director position at the CMQCC after starting there as the manager of their low-dose aspirin initiative just a little bit ago. And we're very grateful for her coming out here to be in person and excited to introduce this fantastic resource that we hope to be able to use both at UNM and throughout the state. So thank you so much, Melinda.
Thank you, Trevor. Thank you, everybody, for being here. It's a pleasure. So I appreciate the introduction, and I'm going to go ahead and get started. So I have put up here that we have no disclosures. And I want to introduce my wonderful team to you guys. So this is our wonderful staff, the Maternal Data Center team, and we have myself, we have a program manager lead. We have 2 program managers, and our program managers do all of our hospital support. And I jump in when needed more for the clinical side. And then we also have our data analysts. In the CMQCC team, we also have a pretty robust clinical lead team of previous LMD nurses and NICU nurse, and also a midwife who do work closely with our hospitals. They focus mostly on our QI projects. We support the data center side. And then we have our crews tech support team that we could not do this work without. And they're constantly working in the background, keeping things running smoothly to answer technical questions, and they're constantly building to update the data center. And that is something I want to highlight, is that we are constantly updating, keeping up to date with national measures, reform measures, Joint Commission, and also we partner with organizations like Leapfrog and US News and World Report to make sure that our data is able to help support reporting of that data. So. Oh, there we go. All right, so let's talk about who is CMQCC and what is the data center. So our mission is to end preventable morbidity and mortality and disparities in maternity care. And that's what we use our data to help drive. We're based at Stanford University School of Medicine. So my environment is much like the environment that you guys are in from the education background. We're a multi-stakeholder collaborative with a focus on hospital members. So we really focus on quality improvement. Everything that we build is based on quality improvement and how we can help support the hospitals and ease the burden on their shoulders for this work, because it's a lot of hard work and it's a really important work. We provide programs and tools to support the hospital QI activities. Some of you may be familiar with our toolkits. If you're not, I highly recommend that you visit our CMQCC accounts and sign up to be able to view those toolkits. They're all evidence-based and based on ACOG and A1 standards, and really help with implementation. And like I said, we're committed to evidence-based and data-driven QI, and that is something that we are really passionate about. So this is a good visual of our organization right now and where we're going. And so we started in 2012 and we started with a couple hospitals, a handful of hospitals, just like you guys are starting with. And over time, we worked with our state agencies, we worked with public reporting agencies to help encourage hospitals to work with the data center to get their data. And now we have all of the hospitals except one in California. And so this is a great lift, and it's been very exciting that we can benchmark and compare across California. So when our users in California log in, and this is our vision for New Mexico, they can compare their hospital to all other hospitals in the state. And I'll show you some of the comparisons you can make, but it is wonderful if they'll have that information. And then we have a couple of big hospital systems that also cross state lines. And so they were like, well, can our Oregon and Washington hospitals get in on this? We love this. And so we did open first in 2014 in Washington, and then in 2015 in Oregon. And we have up here the delivery volumes that we're currently at as of November 1st for these 3 states. We built our national portal, which went live 2 years ago, and our first focus was let's just get a few hospitals in there that are from these system hospitals that know how to use the system and make sure that everything's working well this way, and it is. So we have our national MDC. We now have 5 hospitals to date. You can see we do have one of those system hospitals that's here in New Mexico, 3 in Texas, and 1 in Hawaii. And we have a lot more hospitals coming, so very exciting.
Linda, this is Karen.
Yes.
Sorry to interrupt, but we hear you a lot better if you could just stand at the podium.
Oh, okay.
Thanks so
Sounds
much.
like maybe the Zoom is.
Okay, then I will stay over here. No problem.
Okay, it's just.
Okay, perfect. Okay, so our online tool was developed by CMQCC in 2012 with the primary goal to inform and support hospital quality improvement. And we provide rapid cycle metrics and use data to drive the QI. We leverage existing data, which I'm going to show you. So the sources that you guys are already using, once it's set up by your IT, which we will work closely with, it's fairly easy to just to get the data in there. And for all the users that do have access to be able to log in and see their most current data. State data files are many years behind. And so it's really hard to do accurate real-time work with that data. And in here, users can log in and they can see the data up to about 45 days ago. So every 35 to 45 days, the hospital uploads their discharge data file from the closed out month that's coded and everything. And then all of the calculations are in there. Like I said, we align QI measures with measures that are used for performance reporting. And it's a very easy to use, intuitive navigation of the tool. So I'm hoping that we'll get through enough today that I can actually log in and show you guys just really quick what it looks like. Our customer support, I brag about this because it's really important to me as a leader of this team. And this is something that I experienced the 10 years I used the MDC on the backside as a user, is that the customer support is outstanding. Our program managers live within that help desk all day, every day. Their primary focus, even though they have other responsibilities, is support of the hospital. And coming from a clinical background, I really imparted the importance to them that if we have a leader that's at their desk working on this, they have time right now. They might be going to do an ultrasound, amnio, a delivery in an hour, and they may not get back to this for 3 days. And then by then they forgot what they were working on and why they needed you. So if you have the ability to reply right now, do it. It may not be life or death like an emergency, right? It's not like when your EMR goes down and now we're on paper and we can't see our fetal monitoring strips and all that. It's not that type of emergency. I make sure they know that, but it is super important. To me, it's at that same level because I've been the caregiver on the other side who can't get the info I need and I can't move forward. And then we can't when we're wearing this many hats. So I completely get that. So we do have a highly responsive help desk staff, and we have continual enhancement of the MDC. This is something else I love. I was recently on a statewide meeting call with a couple other data agencies, and somebody asked one of the other agencies, how often do you update your measures? And they said about every 5 years. And I was like, wow, 5 years. We are updating constantly. We go in every time Joint Commission makes a new, puts out their new update. We go through, we compare the coding, we update all the coding. So everything is constantly being updated. And so I do love that about our data center, and that makes it quite unique. This is what our landing page looks like. So when a user logs in, this is where they go. So just at the front, you can see that we have some really important information and metrics, and it's very intuitive. Everything is just click or a drop down. So also it's secure and confidential, which is very important because I know we have data breaches going on across this nation. We want to make sure that only the people that need to log in are logging in and that they're getting the correct security levels. So the hospital administrator, and I don't mean your CNO or CMO, I mean whoever is set up as the administrator of the MDC tool will be the one that's responsible for assigning these roles. And you can have more than one administrator. So it doesn't, we recommend having at least two. Some hospitals have 4 or 5 because you need to be able to back each other up. So these are the different user levels that we have, and you can see that they're quite different. We have a lot of different ones, and it really lets you prioritize and make sure that you can put somebody in here safely who can only look at their project hospitals and only at the aggregated data for the measures that related to that, all the way to the administrator that can manage users and can update ICD-10 coding and working with your coding team and so much more. So it's really important that we have the security in here. I'm going to talk about some features that can support your hospital QI. So this right here shows we have about 236, I think it is now, we're counting. So I put 230 plus clinical quality measures in here that are all perinatal related. That's the key thing right there. Like not only 230, which is a lot, but then it's related to your exact work. And on the right side, you can see these are the categories. And so you don't have to necessarily search when you're in here by the exact name. So you may not know the name, but you know it's a cesarean delivery metric, or you know it's a breastfeeding or a substance use metric. You can click on that category, and all the metrics that have to do with that category will pop up in a list, and you can look up that way as well. We measure hospital performance over time. The menus that are in here have filters at the top and drop-down options, and you can do quarterly, you can do a running quarter, yearly, a running year, monthly. So when you click it, this graph automatically updates. There's no work you need to do. And for those of us that have done biostats in Excel, for many years, this is such a gem. Oh my gosh. I mean, it saves hundreds of hours off the top of work trying to figure out how to make these graphs look pretty. So you can view, like I said, on the different basis of time, and you can look at the different quality measures. If I have the time set up that I like, and I just click at the top, I can drop down to all of the measures and pick the other measure. It will show me that same view. So it's very, very user-friendly and helpful. We have patient drill down screens. This is one significant benefit of the CMQCC Maternal Data Center that we don't see in other data tools, is that you go in and you go, whoa, we've been doing great in whatever your goal is, whatever item we're talking about for 2 years, but we had a horrible quarter. What happened? And you can click in and look down, and you can look at each individual patient if you want. So when we look at the patients, we can see we had a 17.7% here. I like doing this too from the opposite side. We had a great NTSME month. What did we do different? And try to look for a positive trend, right? So that we can mimic that and then replicate it. And so if I click on this 17.7%, what I'm going to get is the drill down screen. So the drill down screen lists all of the patients that are on that list for whatever reason. And we start off with encrypted medical record number. On your side, if you have the correct user access, you will see the MR number, or if your hospital uses account number, you will see account number. Where I worked, I had them put in account and MR because my fetal monitoring system only did MR number. And then when I went into my EMR, it was much easier to look up by account number. So there's a toggle in the top where it says display settings, and you can say, I want to see it by account number. I want to see it by MR number. I want to see it by encrypted number. Let's say you're showing this screen to somebody who shouldn't see MR numbers. You can change it to the encrypted number. That encrypted number is the same encrypted number that my team sees. So we really stress that we don't want you sending us MR numbers. There are other ways to identify which patient you're working on. So if there's a patient like, this was not an NTSB fallout, I do not know why this is on here, and I want it removed because I don't want this, to be a skewed value. You can contact us and ask, like, I don't understand why this is on here. Can you help me? And this is the encrypted number, or paste the URL into our ticketing system, which is basically just an email. It's very easy to use. And then we can get there that way so that we're looking at the same information. Any notes entered by abstractors are also visible to all users. And this is very helpful with the communication tool between departments, between people who are doing evaluations. And that note will follow that patient with any of the measures you're looking at. So for example, if I'm looking at a hemorrhage on a patient and I see a note and I click on it, maybe whoever's some hospitals have one abstractor working on all this and some have 10, right? So maybe another abstractor was doing timely treatment of hypertension and there's a whole note in there about their preeclampsia. You may not even have known looking at it that this was a patient that was diagnosed with preeclampsia and had been treated, yet because you were working on the hemorrhage area, but now you can see their note. And then if you put a note, they can see that note too. And so that's really, really helpful when it comes to the communication. And also it might help you remember things when you come back in. Because like I said, with those busy minds, and then you come back, you're like, oh yeah, that was that patient that I made those notes on. So very important. The functionality enhances data transparency and it allows for more comprehensive reviews and understanding of each patient's medical situation. As you can see on here where there is the orange circle that I just put, if you hover over an ICD-10 code, I don't know about you guys, but I've been working with them for years and I do not have the majority of them memorized. It will tell you what the code is. And I love this because for our SMM, for some of our measures, if you see a bold one, that's the one that coded that got them into that group. So it will really help you identify it. Sometimes it's not coded properly. Sometimes it's coded properly based on documentation that may not be correct. We all are humans and errors are made. So it really helps us make our data more accurate. And it also helps the processes. Doing this work, I had no idea that I would become so involved in process improvement, but I definitely started noticing some trends that I couldn't let go. And so then I went back to my teams and we really worked on how can we improve this process and what can I do to help you be able to find the information you need. Maybe we need to update a way a note is being done. You know, it's all about support and process and helping each other. And so this is a really, really easy and good way to be able to identify those items. We have the ability to benchmark and to do comparisons. This is also done in a very data private way, if you will. It's probably not the best wording, but so as you can see here, I can do a comparison against all other NICUs in the MDC that have the same NICU level as me. I don't see who those hospitals are. I can't see their rates, but I can see an aggregated rate of all of the other NICU levels the same as mine. So whatever NICU level your hospital is designated as is what will be in the system. You also can compare against all MDC. So New Mexico, if we have a portal that's just New Mexico, which is our goal, then you'll be able to compare next to all MDC users in the MDC or all MDC users in New Mexico. And so that's so important, right? And then you can see, wow, compared to all the MDC, we're doing this compared to the New Mexico, which is much more indicative of the processes and the population and everything you serve, we're doing this. And so it really can help, you know, give you a visual. This is one of my favorite screens and it is so simple. So I did an NTSV project and we brought our rate down and people weren't really that excited about it for some reason. I mean, some people were super excited and there were others that just didn't really, I don't know that they really thought of the impact or where we were. And I went to an OB department meeting and I presented 2 years into this project. We were all the way over to the right, like maybe 10 from the right, which is one of the highest in the state. And that is not where I wanted to be. We ended up about where the orange is. And so when I was just be able to call this up, and I said, the blue is all other MDC hospitals and the orange is where we are. Look where we were 2 years ago. And the whole room gasped. Like it's very impactful to see this. So this is not one of our typical graphs that you would look at like every month, but it is great to see over a long period of time how well you're doing with your work and maybe also help identify where we need to focus some efforts. This is another one of my favorites, loving quality improvement, is working on balancing measures. And I think that sometimes this is a forgotten tool and this is already built into the MDC for you. I actually would love to expand upon this and have it select which balancing measure goes with which measure you're working on. That's a goal of mine in the long term. But right now, what we have is we have compare two measures. So you can pick any two measures, and that's not something I would take away, but I would just add to it. You can compare any two measures and you can see, well, as we're improving our NTSV rates, are we increasing our unexpected newborn complications? Because that was a big concern for a long time, right? And really across the nation, no, we're not. We're actually seeing better outcomes. Some hospitals don't have that though. So it's important to look at it because those individual hospitals or maybe departments, maybe their processes aren't what they need to be. Maybe they aren't going to the OR quick enough for category 2 tracing, right? Maybe there's other things that they need to look at. So they really can identify that and say, wow. So we can see we had 1 quarter here that's way off. Most of the time as our rate dropped, our unexpected newborn complications dropped. But when we get into Q4 2021, Our unexpected newborn complications dropped when our NTSV rate went up. Oh, and then other ones, it was the opposite. And so now you can point at the quarter and you can say, well, wait a second, we need to look at this and we maybe need to see what we did that quarter. Maybe if you're looking at long-term, that's 1 quarter, we know 1 quarter, we're not going to worry about, right? We're looking at 5 years and 5 years is amazing. And so it really gives you that picture. And once again, on here, you can change how you want to view this. You can view it by year. Some hospitals have 10 years of data in here. So it's amazing for them to look at this year by year. When we go live, hospitals sometimes, most of them will upload their data all the way back to 2011. So we have the ability for you to upload your data back to 2011, which is really, really amazing to be able to look at some of these rates all the way going back. And so that's exciting to be able to do that. Okay, next item. So measure analysis. We have a measure analysis tool, and this is based on some of our specific measures. And what this does is it allows the hospitals to implement targeted quality improvement aimed at improving outcomes. So they can look at what's driving the rate, which sub part of the measure is driving the rate. And so if we look at this, and this is on the main trend screen, by the way, when we look at this, we can see, for example, here is for NTSV, or actually, I think this might be general C-section. And we can see that our Brightenburg Medical Center, which is, this is one of our demo centers. I have no live data in here that I'm sharing. Their spontaneous labor cesarean sections are 11.5%. That's much higher than what the rest of the NICU levels are in the state. And so is that an area that maybe they need to focus some efforts on, rather than saying, let's work on our C-sections. Let's work on reducing our C-sections. You can now focus, let's work on our C-sections for our patients that come in spontaneous labor. And maybe we can identify that our spontaneous labor is a fingertip and contracting every 10 minutes. And that's why we're admitting them, which is maybe why we have a higher C-section rate, right? And so you can start focusing on and go, oh, that standard that they wanted us to implement that we didn't want to, maybe we need to. And so this really can speak volumes to people, and also show you that maybe an area you thought you needed to work on isn't what your primary driver is. And it changes over time. I mean, it changes as your populations change, and also as your staff changes and your processes change. Great to be able to see it. I think I'm gathering from the information I've got the last few days that this is actually something that's not done very widely in New Mexico. This sharing of provider metrics is like key in California. There's very few hospitals not doing this. And it took a long time. So I don't want to be up here making you guys think that, wait, if they're doing it, it must be easy. It wasn't easy. And I know I'm speaking to providers here, and it's a sensitive topic. And so things were done in a very stepwise fashion. And really, once providers and nurses and leaders started seeing the impact that this had, that's when they really started pushing for it. So this is actually in our toolkit as a tool that can be used to help drive the NTSV rate reduction. And there's also some other things, like I used it for timely treatment of hypertension. I just had one doctor that was like, you can't tell me what to do. You're a nurse. I don't care. No, I'll come see the patient in 2 hours. I'm like, we don't have 2 hours. You know, she's going to code on us. And so I was able to show with this, and I didn't even have to put up names. I just blinded it. But when he could see that he had this many timely treatment and everybody else had 85%, he was not happy. And so, yeah, it's really, really amazing how we think we're doing something really well and we may not be, or vice versa. You might be beating yourself up thinking, gosh, I'm at 24%. And then you realize everybody else is at 26%. You know, maybe there's something in your patient population. And so this is really, really helpful. So there's tools we have about this. We can talk about this more, but we have the ability to do this. And if you look in the let's see, if it's not on this one screen that I have the screenshot, but you can put a minimum denominator size, first of all. So if you have a doctor that does 1 delivery a month, you may not want to show their NTSV rate, because then they're going to have 100%, and that's going to throw them off, right? So you can pick your denominator. If you're doing a year of data, that's different. Then you might, be okay lowering the denominator. So it's really, it's a really great, and you also can decide if you want blinded, if you want it by medical license, if you want it by an encrypted number. So like I know who it is and the leader knows whose it is, but nobody else knows who it is, or by name. And the name is obviously the long-term goal, but that's not how you start. And so it really is a culture, and it's a frame of mind shift. Birth equity. This is a huge topic across the nation, as we know, and as it should be. We have built a lot of tools into the MDC for birth equity. In California and a little bit in Washington, the states are mandated to report aggregated data and also more granular data by race and ethnicity. That's a really hard pull from IT. And it's really hard to get this measure broken down by this and then this, and so this does it for you automatically. Also within here, we have links. You can see it says see more here and it says see more here and it says birth equity resources. Each of those takes you to a user guide or a tool or some sort of standard recommendation, and it has everything sourced evidence-based. So it's really wonderful. We also caution in our system, any item that you see that has a little circle that's open instead of solid is a denominator less than 30. So we caution evaluation of that. Some people have come up to me after my talks and have said, that's the population probably needs it the most. Why would you tell people not to evaluate it? And I want to make very clear that's not what we're saying. You are right by that. We need to evaluate those, but do it with caution. Like I said, if you have a provider with one delivery in the month and they have one cesarean section, they're going to be at 100%, right? And so I know all of you understand statistics and why we would want to be cautious with that. This is a breakdown of birth equity data. So this is our NTSV rates by the different races that we have in here. And I believe that we'll be building some different races for New Mexico based on what your state needs and how you guys break down your races. This is how it's done in California. Washington and Oregon have a different one. One day we'll all have the OMB federal standard, but the states aren't quite there yet. And so just know that you have the ability to do this. Who likes reviewing severe maternal morbidity charts and records? It's difficult. It's hard work, right? But it's so important. We have an SMM module in here. There is a spreadsheet, or not even a spreadsheet, a worksheet that can be downloaded and used and never re-uploaded into the MDC. We highly recommend its use. It also can be completed electronically and then uploaded into the MDC, which a lot of our hospitals do. We would like to see more of them doing that because what it gives you afterwards is what you're seeing here. So I can see here, condensed from the CDC's 21 severe maternal morbidity complication indicators, this MDC table shows the categories that comprise severe maternal morbidity. So we've broken this down into 8 categories. If you hover over category, you'll see that this one shows that what's in there is DIC, shock, and hysterectomy. And so that's what's under the hemorrhage one. And so this really can highlight different areas. And you can see, wow, we had 0 sepsis, way to go. We had 0 cardiac, awesome. We had 3 hemorrhage. You guys know, sometimes you can't prevent a hemorrhage and sometimes there's nothing you can do about needing a transfusion. Because it says that doesn't mean anything bad, that you did anything bad, but we won't know unless we evaluate it, right? We won't know if there's opportunities unless we do. And this takes you right there. You can click on the 3, it will show you those 3 charts. And then you can start going through them. You can get the MR number, you can get the account number, go into your EMR, and you can do a deeper dive. But what it does by leveraging the data that you already have, it uses an algorithm in the background that looks for ICD-10 coding for one of those 21 SMM indicators. So if CDC changed it next year to be 20 or 22, we would update the data center to automatically reflect that, and you and the users would not have to do any work on that. That's a question I get sometimes. What do we have to do to get that? Is it more expensive? Is there an upgrade? No, it's automatically rolled out on the same date that the organizations roll them out. We have our Joint Commission's maternal safety standards in the MDC. Already built exactly word for word how the Joint Commission has them. Once again, if they update anything, we will update it as well. Going through here, I showed this little picture here because I want you to see that this is just number 1 out of, I think there's 8, or I can't remember how many there are, but this is only number 1. And it actually goes longer than this because we source things out. We go in here and we say, what's the rationale? Here's an example action. Here's a resource document, our hypertensive disorders of pregnancy toolkit, and go to the section accurate blood pressure measurement on page 45, and it will help you complete this. So not only do we show you the wording and what Joint Commission is needing, but we also give you the tools to help implement that. We have the ability to confirm that this is in place and the ability to say that it's not in place, because that way when you run a report, you can work with your team to say, we have 5 of them, we need these 3. And then you can reaffirm. So we request that our hospitals reaffirm yearly. And that way you will also get a message if you haven't reaffirmed, and you'll know like, maybe we need to look at our hemorrhage kit. Maybe we need to do certain things and make sure all those processes are still in place. Because we know We're human beings, and sometimes if things don't get used, sometimes people just stop doing them, right? So that's a really good time during that reaffirmation period to go back in and make sure that all of those guidelines are being followed. Like I said, there's implementation resources provided. This is a reaffirmation that I showed you, and I see it says must enter date off to the right. This is standard number 2, and you can see it's built the same way. However, it says the resource document is Hypertensive Disorders of Pregnancy Toolkit Appendix K. So it's pointing you to a different place. So this is sample nursing management policy and procedure. Where we can, we have worked with some of the leading hospitals in the nation to get a copy of their, or a sample of a policy so that the hospitals can look at those. And it's a sample. You will need to customize it to what works for your unit, but it's much better than starting with nothing. So this is awesome. And there's the ability to have a PDF report. So who doesn't like reports that automatically print? You can go in and print it. Like I said, it will show you where you need to focus your efforts in your implementation work, and then you can maybe assign that or work with teams to get that done. So this is a great tool to be helpful. Going along with that, for years, we only had those 2 built in there. Washington and Oregon are AIM states, and they report to AIM. And so they helped us get the AIM bundles built into the MDC. We built them, but they helped fund it, and they also helped us collaborate with AIM, and we have a relationship with AIM, so we were able to do that. So if you were to go onto the AIM site and you were to call up any of their bundles and you look at the data collection document they have in there, that's what we build it from. So everything is exactly the same. The recommendations are the same. What data is collected is the same. The numerator and the denominator, it's all figured out for you. You don't have to figure that out. So on your home page, if you will, your landing page, you will see this QI initiatives tool. And all 10 QI initiatives that are drivers of maternal morbidity and mortality are in here, but only the ones that you have said that you've started your work on will be on your landing page. So if you want to get to the one that you need to start, you would just click on the top where it says all 10, and then you would be able to be at this screen, and you can go in and you can click document QI activity, and boom, fill in 3 boxes, I think it is, and it's documented that you're working on it. Where we see action needed, if you hover over that, you're going to get this little box that shows you what's needed. So it might tell you that you need to reaffirm that you've completed it. It might tell you that you need to complete last month's, data reviews. And so it will guide you. This is what it looks like once you're inside. And so this shows for our I think this is our substance use. Yes, if you see substance use is in the orange at the top. So this is our substance use. And we have all of the tabs for the different primary drivers of maternal morbidity and mortality at the top. So you can go and you can click on them if you just want to go to one of the different screens. It's very easy. And so this is just the very top part of our substance use bundle that's built in here. And the items that have an A next to them, those are AIM measures. Or those are, items that we got from AIM. So it identifies those easily for you. And as you can see, the last 4 quarters of information and data is right there on the screen for you. I mean, it's so easy. If you want to set a target, you can click edit next to the target and set a target. So if your hospital comes up with your own target, you can customize your target and put that in there, and that will communicate that to your whole team that this is our goal. So clicking document QI activity will take you in, and then we talked about the AIM and we talked about those. We have a section in here. This question comes up a lot. How will we know if there's something new? Well, you go to the what's new section. As you can see at the very top of the page, we have this MDC admin support what's new search. It's on any page you're on. That's like a stable thing at the top, kind of like the header on your patient's EMR record where you can see their BMI and their allergies and their name. It's the same type of thing. It's always there. So if at any time you need to search a word to get something, you need to do any of that, go to support, you can do that. And what's new will take you to a section that looks like this. We don't update this too often, but we update it often enough. So we put the most important items in here. If we were to put every single change we made right here, nobody would want to read it. So if we see a misspelled word, we don't put it here, right? But when the US News and World Maternity Services survey is ready, we put it here so hospitals know. And then every couple months, we also send out a hospital communication that is very structured. It's the same look every time, so you know exactly where to go. It talks about what webinars are coming up. It will talk about any items that we've updated. And so we send that out additionally. So that's how we communicate to our users exactly what is going on. So we have data submissions for supplemental items. So there are some items in here, for example, breastfeeding, human milk feeding. That's really hard to get out of a record automated. Like you have to go in and do some chart review. Same for timing treatment hypertension. Kaiser's been trying for years to have their IT team build, how can we just get a report that says whether hypertension was treated in a timely fashion, and it's impossible. They've got it down to just the first high blood pressure, but then after that you can't. And so at least it's giving them like a focus. If even the first one wasn't done, they know it was a fallout. So now they don't have to review those ones. So it is helpful, but it's still not robust enough. Computers are great, but we need humans. And so this will help you because when you figure out how to upload the supplemental data, you can do your reviews and you can get the data back in here. So one way it gets back in here is by manually entering it. I did that for 3 years. It wasn't fun, but it was doable. Another way is for your IT team to build a report that gathers the data and then to submit it. For timely treatment hypertension, that's pretty hard, but you can have them build some reports that will help. For example, a medication report for the patient, also maybe a vital signs report so that you're not going into all these different places in the EMR. You just have this and this on the patient and you can look it up on the screen. And that makes your reviews much easier. So when you can manually or you can submit, and when you manual, this is what it looks like. It is so easy. So it's not that it's difficult, it's just that it's time consuming, right? The information is information. So for this is our PCO5, we put in, was it a NICU admission or not? And was the patient exclusively human milk fed? Was the newborn fed that way? And then it will tell you with a check to the right that this chart is complete. Once all this is done, you get to the bottom and then it says to view the measure and you can see your measure right away. You don't have to wait an hour. You don't have to wait a week. It's right there for you. Something else that I want to point out here is that you can see the delivery date, the discharge date, the encrypted medical number, or on your side, you'll see the regular actual number, and which helps you then know which chart to go to if you need to go in and do a review. This is leveraged from your patient discharge data file. And what we have in the data is the hospital has this patient discharge data file that all hospitals have to submit to the state. I don't know if you guys are aware of that. That data file is the same data file that's submitted to the MDC. So the IT team submits that, and then it pulls all ICD-10 codes, it pulls all the information it needs to calculate that 80%, 75% of the measures. One like this that isn't calculated, it still leverages the data. Because on here, we don't have patients that are less than 37 weeks. It's here, but see it says gestational age less than 37 weeks, excluded from measure. Yes?
So can hospitals submit ICD-10 codes from
Survey number 27, that's
MDC rather than from the discharge codes that are used for billing? Because your codes seem like they should be better than the ones that are sent to insurance.
So the codes that we get in here are exactly the ones that come from that same file. The only difference is if you guys make any edits because you notice errors. And what we then always recommend is don't make those changes until you work with your coding team, because we want the EMR to match what's in here. We don't want you to run, let's say you could run your NTSB rate easily from your EMR. We don't want that to be 29% and this 22 or 22 and 29. They should be matching. That's the goal, is to have them match exactly.
Do you have data on improvement on code sent to billing for the hospitals that have been part of MDC over time?
I don't believe we do, but that's a really good question, because I know when I was working in quality management, I helped a lot by working with our coding team to help us get reimbursements. That was really the talk that I had to have with them, was like, we're losing out on money, how can we work on this? And also our measures aren't accurate. And so, yeah, that's a really good question. Thank you. I will take that back to my team.
Well, and it should improve national data, because a lot of our national maternity, our M&M data is coming from discharge coding. And so you're improving the quality of that data, especially.
not them, us.
You will. Yeah. But I love her thinking. Yes.
Right? It's like if people.
This is a win for.
Yes. Yes, no, I think this is great. I think this is one reason why I love working with all these amazing minds, because people have such great ideas, right? So I love that question, and that's a really, really good question. So like I said, this is easy to complete. You can edit the data as needed. So if you thought you had a NICU admission and then for some reason it wasn't, you can just go back and click on either box. There's no like anything else that has to happen. It's all up to you. You guys own this, and this is your information. And the measures calculate immediately. That's the other thing that's amazing to me. me. So this is what you would see when you then click on view measure result. Boom, you have your record right there. You have your measure and you can print it. You can print a PDF, you can do a screenshot, whatever you want with it. And I also love that it gives the definition at the top. So it says this result is exclusive human milk feeding during the entire hospitalization among non-NICU term infants. So you know what you're looking at and it tells you right there. Data quality, this is something we were just talking about. It's so perfect. So the left side shows this little box and there is an area that says data quality measures that is on everybody's homepage. It was at the bottom though, so I didn't have it in the screenshot. There are 36 different data quality measures that you can look at. This area is a wealth of information, you guys. Some people aren't focused on this. They don't need to go there. Those that are, this will be your best friend. So on the right side, we can see, let's look at the 92.9% towards the bottom. This hospital has a 92.9% missing or inconsistent Medicaid status. The goal is less than 5%. We've identified an enormous process issue that we need to work with our leadership, right? If we look at the missing and inconsistent birth weight among less than 2,500 gram newborns, and yes, I know, when we have a 2,200 gram newborn, we aren't caring about the weight right now, right? Like we got to get that baby out to the NICU, and I get all that. But when babies are transferred to other hospitals, now, how do you know the weight? You don't, unless you come up with a process to figure out how you can get it and put it in to complete your record. So if that's something people wanted to work on, they could. It highlights, no one's alerting or fining or telling you that you're a bad hospital. It's just a highlight on a process that you may want to focus on. We're towards the end here and I want to make sure that we have time for questions. So I'm going to rush through this a little bit quickly, but so we have a lot of things that are included with being a part of our MDC. So all the features are included. This is not one of those things like piecemeal and you don't get that and you don't get this. You get all of it. Okay. It's just, you get the MDC. A system dashboard, if applicable. So if you have a hospital as a system, 3 hospitals, 30 hospitals, it doesn't matter. The administrator level can see a system dashboard where they can see all their hospitals and the main primary measures that they want to see. So they can look and really have like a dashboard of their system. One-on-one training webinar. Our team will put together a custom webinar for the hospital or the hospital system based on what the needs are for their onboarding so that they know how to use the tool. We don't just say, yeah, you bought it, go. You know, it's like when you buy a new car and they sit in there and help you set up your phone and do all those things. We will do that with you. So it's very personal. Customer support, we're open Pacific time zone hours, which works pretty well for you guys. We have some groups like New York and Minnesota, which that's gonna be a little rougher for. I have no problem updating my hours on our side, on our team as needed. So if that doesn't meet your needs, you let us know. I think it will based on the responsiveness of our team. Specialized reports to facilitate reporting to external reporting organizations is huge. I'll give you an example really quick. HealthNet in California is working very fiercely on NTSV. They have partnered with their hospitals. It's in their contract that they want them at goal. And if they're not, they'll still work with them. They may not get the same incentive, but they'll still incentivize them to, okay, you're at 30%. How can we get to 28%? We will give you this improved reimbursement if we can get you to 28% by next year. But here's a caveat. They tell them in their contract that, and this was their idea, that they have to report it through the maternal data center. So HealthNet gets one report once a year that's from the data center on the HealthNet hospitals. I don't release the data unless the hospital tells me I can. So I don't want you guys to be fearful that I'm gonna start sending your data places because I absolutely will not. There's an internal form where the administrator can click yes. Please release only my NTSV rate to this person during this time period, and they can go at any time and revoke it. So when I go in, I only send it to those on the Excel spreadsheet that I print out based on who approved it. But it's so helpful to the hospitals and to HealthNet and to our patients. And then we have CMQCC member-only webinars that we will advertise and promote. We have assistance with learning to use the MDC, like I said, and we have user group meetings several times a year where we will have a little like summary of all the updates that we've made to the MDC and how to use those tools, and customer support upon request. This is the end here, and then we can ask some questions and I can go to my home screen if you'd like. This is, we surveyed hospitals and we said, how do you use the MDC? And this is what the hospitals told us. So this PowerPoint slide deck will be available to you guys. I'm not going to read every single one, but there's a lot of great reasons in here and a lot of great ideas. And then we asked them, why do you prefer the MDC over other tools? Why would you use this over other tools? And these were the reasons they gave us. I've only ever used MDC, so I can't compare it to anything else. But there are hospitals that have been. And, you know, I was blessed that when I started in my QI journey and I started working on this, my hospital was a part of the MDC and I never had to do anything else. It's all I know. But when I hear these stories, I'm quite shocked. So it's exciting to see this list that came from our Qualtrics survey. This is a quick example of our, the US News and World Report, for example, and how people can go in and they go to the reporting.org section, and then it gives them a list of the 20, you know, ones that are in there, however many there are, and they can click on it and says, see my hospital action steps for using this MDC for reporting this program, and it'll tell you. So some of them, like that Health Now one, we send them the data, but a lot of these, we don't send the data at all, but we provide a download where you can go upload it to AIM. You can go upload it to where it needs to go. All right, so we're at the questions time now. I can log in and get to a home screen if anybody wants to see something. All right. And at the end of the deck, oh, we have 2 chat questions. I'm sorry, I did not see this. Okay, perfect. We do have our contact information in here. And so if anybody wants to get a hold of us, they can. Please feel free to reach out to me at any time, you guys. I love it. I love what I do, and I love what I'm working with and who I work with. So I'm here for you guys. Yes.
Is there a thought that in the future, MDC would expand to include early pregnancy?
Yes, we're working on that. That's another great question. I'm not texting. I'm doing my Duo 2, the 2 identification, authentication, whatever it's called. So our LDA project that we're doing, a low-dose aspirin project with March of Dimes, really was our first time that we delved into the prenatal area, because we really had to engage our prenatal clinicians. And I actually was leading that project on the clinical side, and I was going out to the clinics that were involved in our first pilot. So, you know, we had 6 hospitals, we had 30 clinics, because hospitals have very many clinics that feed them, right? So I went into the clinics and I worked with them, and I was like, let's do this. How can we educate like that? I mean, it's done very differently than it is in the hospital. So really working with them on that QI model. It's not just about room time and about their immunizations. Like, we need to, you know, to look at a different way. So we worked on some PDSA cycles with them, and we're helping the March of Dimes write a toolkit for how to implement LDA project. And with that, we have even more respect and more understanding of the need to really have that data in the MDC. So currently our LDA data is based on med reconciliation on the admission, because we only have admission data. But we're actually doing a readmissions build right now. And so that will be huge to be able to see your readmission rates and your SMM based on readmissions and all of that. And it will also be a neonatal too. So if a baby's readmitted for hyperbilirubinemia or something like that, you'll see those in there. And then working with that, we want to start working with the clinics and see how can we get the clinics to work with the hospitals to be able to use the MDC to leverage some QI in their area. So I hope that answers your question.
Wait, can I just- this is basically built to create reports and data about what we capture in our birth law. And I wonder what you're talking about is more people who present for pregnancy miscarriage, whatever it is, which is a different set of.
And it's really hard to find that data nationally or at state levels, because there isn't typically an admission in a hospital that generates those codes consistently.
But if we produce a report about that, we can create a custom report of this and watch it.
And we work with our hospitals. So yes, I'm from the Perinatal Quality Collaborative in California, right? I'm not from the Perinatal Quality Collaborative in New Mexico, but your Perinatal Quality Collaborative and you guys as UNM, you can come to me as the director of the data center and say, we would really like this measure. So in our scope of work for next year, can we look at what that would look like? How much would that cost? And if this is a focus that you guys want, we can build that for you. I know that we're also working on some support of documentation around midwifery care. And that's something we're going to be doing, you know, regardless, but I think that would be really helpful in New Mexico too. I know that's not what you're talking about, but you know, there are changes and updates that can be done. Yeah. We definitely have a goal of making this the best it can be, not just keeping it like it is. And that's something I love about it, is that we're constantly updating it. So this is the home screen. Is there anywhere anybody wants me to go? Scrolling down, you can see what's down here. Here's our data quality measures. And so if I do click by name, it automatically gives me all of them.
Being able to create like Excel, like download it.
Uh-huh.
Download the data.
You want to see something like that? So let's just say we go to our favorite PCO2. So first of all, there's graphs and data downloads here, and you can download a PDF or a data spreadsheet. The other thing you can do, and this is what I lived a lot in with NTSV, because while we do need to look at NTSV rates over time, I reviewed every single one and I marked all of them that were true fallouts. So if it was a category 2 and they go to the OR, it's a fallout technically, right? But if it really needed to go to the OR based on my experience with fetal monitoring, then I didn't count that one because what we needed to save a life, right? So we went to the OR. So I really looked at all the ones where maybe we could have done better. And then I tried to find those patterns. So the way I was able to do that is that I would go into a month. So I'm going to click on this month and go into the drill down here. And you can see we have this drill down. This is a busy, busy hospital. Yeah, this is for a month. It's a busy hospital. And you click download Excel. It's just so easy. It will give you everything that's on here plus more. So it will give you all that. You say that you agree to the data, security that you should be looking at that, but it will give you ICD-10 codes. And then let's say you wanted to start, we have compare 2 measures now, so you don't really have to do the download for that. We didn't used to have that, but you could go in here, even your comments are downloaded. So like if I hover over here, I can see their comment, it says fetal distress. This one says for discussion. This one says fetal distress medically indicated. So there was somebody doing this review and they went in and made these notes. And now the next person going in can see, oh, Susie Jones, she's really amazing. And she reads, strips really well. I trust her that this was fetal distress, that type of thing. So it's really helpful. And then Excel downloads help that. So when I go in here, it's going to ask me if I want demographics, I want the measure status, I want the ICD-10 codes, I want the delivery variables. So I'm going to pick what I want. And you can say include identifiers in file or don't include identifiers in file. So maybe you don't even care who the patient is as far as you're never going to go in the MR. You just really want to look at certain data. So this is doing for May through July 2019, and I'm going to click download. This is going to take a minute, which is why I don't usually do it, but I want you to be able to see it. So it takes a couple minutes. Usually at this point is when I'm going to get a cup of coffee while my report downloads. Okay, so here we have it, and I can open it, and here it is. Now, because this has no patient identifiers, it downloaded without any sort of password. If you include identifiers, you have to give it a password. I love and hate this at the same time, that you cannot change that password. And if you forget that password, you have no access to your file. Believe me, I've locked myself out of so many things. But the utility to that is nobody can ever break into it. And that's why that's so important. You can always re-download it if the data's not gone. And you saw how quick it was and easy it was to download it. But yeah, it's frustrating when you're doing your work and you're like, oh, I needed this from a year ago. I don't remember what password I used a year ago. So if it's something you might want to do again, write down your password. But yeah, this is what you get. I mean, and this is like a wealth of information. And people that are good in Excel can turn this into all sorts of fun stuff. I mean, this brings in, look at, were they in the timely treatment of hypertension? Did they exclusively human milk fed? It has everything.
But that being said, your preset graphs and reports have so many filters.
Absolutely. So we have built that over time because this is what we do also. Let's say I get a help desk ticket that says, how do I do A? And I tell them, this is the way you do it. And then you're going to do some sort of graph or, pivot table from here. And then let's say 2 months later, another hospital asks the same question. And 3 months later, another hospital asks another question. I don't ignore that. I go to my team in one of our tech meetings and I say, I think we have something we might need to build. We've had 3 hospitals in the last 3 months ask for the same thing. If 3 different hospitals are doing the same thing and they're totally different, not in the same system, that's something we need built in here. They shouldn't have to do a custom report. And so we are building all the time. And that's a really good example of that.
Could we show maybe one of the measures and breaking it down by race, going trends over time, just to show people some of that?
Yes, what was that? I couldn't hear you.
Do we do like the NTSB broken down by race?
Yes. Where's my mouse? It's not coming up. Oh, there it is.
Just while Melinda's pulling that up, we have a grant to start up a state portal and to get about 10 hospitals onto the MDC over this next year. And so I know for those of you who are participating from other hospitals, thank you for being here. Please contact me and we can start working on the specifics of how that will work.
All right, so we're in NTSV here. You saw I just clicked one thing to get in here. I can see my hospital trend. I can go down into patient level data. We saw that. Oh, we have an advertisement. I can look at the definition algorithm. So if anybody ever wants to know, look, it's excluding these. And then as of January 1st of this year, it's also excluding placenta, creta, increta, percreta, and vasa previa, thank God. And we update it as we go. And so you also can do an intervention chart. These are all things that are built on everything. So this one shows during a project that right here was their baseline. They started the RN education here. They started using peanut balls here. So you just literally, you hit add period and you fill in each of these things. That's it. It pops it on here for you. This is really, really helpful to go back to your staff and say, look at what a difference this one intervention made. We need to do this forever. It gives them this visual. If we go into measure analysis, which is I think where Trevor was talking about, this is going to now analyze it for us. And this is how we get to the area that shows us spontaneous labor, induced labor, no labor, total NTSV C-section. And this is where we do our comparisons. So if I click on peer, I'm going to be looking at other hospitals that have the same delivery volume and other hospitals that have the same NICU level, and then the whole MDC. And then I can compare kind of where I am with those. We have a system one if it is part of a system. So this is all of our demo hospitals and it shows the systems. And then you can go by NICU level, all hospitals. And then if we go down to the bottom, we have race and ethnicity. Tell me if it gets any harder. I mean, this is like the easiest thing you can do. I clicked on it and boom, it's all right there. It's like magic. And so we can see that we may have a disparity here. That's Alpha Medical Center may have a disparity with how high some of these rates are, and we need to go in and look. This one is out of 2. And it's, you know, there's 1 out of 2, so it's 50%. That doesn't mean we don't look at it. It just means we're a little more cautious with the interpretation. This one is still really high and it's got 24 cases. So we really want to look at that. And when you start looking at these cases individually, for those of you that have done that work, it really can be a wealth of information. The compare to measures is right here. And this is where I was talking about that you can go in and I can say, NTSV and what's something else you want to see. I mean, I know anemia on admission has nothing to do with it, but we can say anemia on admission. And so you can put any other measure that's in here, you can put with it.
Got one question from the chat from Dr. Phelan, who asks, is there an ideal size or minimum size of the healthcare system or hospital to benefit from using the MDC?
I think that it doesn't matter how small or big you are. I think that one of the downsides for small hospitals, and it's not a downside of using the system, it's just something that they deal with across the board, is the lack of resources, right? You have a big robust system, you have an IT department, you probably even have like if you're an Epic, you have an Epic store analyst, like they do OB, that's what they do. But when you have a little hospital, you don't have that. And so it's a little harder, but our program managers are so great at working directly with the IT department, working directly with the leaders to help get what we need to be able to build that. We have 3 hospitals right now that signed contracts probably a year ago, and they don't have their data up yet because they kind of gave up. And I came back to them like a month ago. I'm like, let's revisit this if you want to use it. If you don't want the contract, I'm not trying to like keep you as a customer. No, they want it. Their IT department was like, it's going to be $15,000 to build that, which I've never heard. 3 hospitals out of the hundreds that we have. So we went back, they completely had misunderstood what needed to be done. And so our tech team is so good. You know, Trevor, because you've worked with Andrew, really, really good at the technical part of it.
So we'll be around a little bit longer for people who want to stick around and chat, but thank you so much, Melinda.
You're so welcome. Thank you, guys.
It's kind of a chat out and warning call. The work to do this well, to improve the quality of care for our patients, what we're all here to do, is going to require some big work with the discharge side. And how we feel really how to write. This sort of stuff.
Thank you, guys.